Hey everyone, welcome back to Nephrology Board Review. This is On Call series number 2. And if you watched the first video on blood pressure drops during dialysis, you know the format. We take a real on call scenario and walk through it step by step so you know exactly what to do when your phone rings. Today's call is one that should make your heart rate go up a little bit: chest pain during hemodialysis. This is the call where you have to get it right because differential ranges from something totally benign to something that can kill your patient. And the whole challenge is telling those apart quickly over the phone with limited information. Specifically, we are going to focus on the big question: is this ACS or is this a dialyzer reaction? Let's get into it. So, you're on call and the dialysis unit calls you. Patient started having chest tightness about 30 minutes into treatment. Blood pressure is okay, but they look uncomfortable. Now, notice what the nurse said: blood pressure is okay. The patient isn't crashing hemodynamically, so it's tempting to think that this is nothing serious. Maybe musculoskeletal, maybe anxiety. But here's the rule I want you to burn into your brain: rule out ACS before you attribute chest pain to anything else. I don't care if the patient is 30 years old, I don't care if they get chest tightness every session. Until you have an ECG and a troponin, you're not allowed to say this is benign. Period. All right, let's gather information. Here's what you need to ask over the phone. First, what's the character of the pain? Is it pressure, tightness, squeezing? That's concerning for cardiac. Is it sharp and pleuritic? That points more towards pericarditis or potentially PE. Is it vague and positional? Maybe musculoskeletal. Second, get a full set of vitals, including an oxygen saturation. You need a baseline right now. Even if the blood pressure is okay, I want to know what the exact number is, the heart rate, and the oxygen saturation is. Third, did hypotension precede the chest pain? Because if the blood pressure dropped first and then patient developed chest discomfort, this could be demand ischemia. The heart wasn't getting enough perfusion and now it's complaining. Fourth, what's the cardiac history? Do they have known CAD, any prior stents, prior MI, bypass surgery? This changes your pretest probability dramatically. Fifth, and this is one people forget, is this a new dialyzer or new bloodline? Type A dialyzer reactions classically present in the first few minutes of treatment with a new dialyzer. If the timing fits, that jumps up your differential. And sixth, any associated symptoms: shortness of breath, diaphoresis, nausea, back pain, or itching. Each of these points you towards a differential diagnosis. Let's organize the differential. Same framework as the last video: common, concerning, and don't miss. Common causes: musculoskeletal pain. These patients are sitting in the same position for 4 hours, and sometimes their chest wall just hurts. It could be anxiety or panic, especially in a newer dialysis patient who aren't used to the process. And pericarditis: uremic pericarditis is a real entity in ESRD patients, and it can cause sharp, pleuritic chest pain that changes with position. It improves by bending forward. Concerning causes: ACS or MI. This is your number one rule out. Arrhythmia due to electrolyte shifts during hemodialysis, which can trigger dysrhythmias that present with chest discomfort, and type A dialyzer reactions. These are IgE mediated hypersensitivity reactions to the dialyzer membrane. They can present with some chest tightness, dyspnea, and a sense of doom. And the don't miss category: cardiac tamponade. Uremic pericarditis can progress to a pericardial effusion that compromises cardiac output. Air embolism is rare but catastrophic if the dialysis circuit introduces air. And pulmonary embolism. Dialysis patients have central lines, they are sedentary, and they are in a hypercoagulable state. PE should always be on your radar. So here's your action plan. 5 steps in order. Step 1: get a 12 lead ECG immediately, not in 20 minutes, not after treatment is done. Now, this is non negotiable. Every minute of delay in diagnosing a STEMI is myocardium dying. Step 2: check a troponin. But here's the nuance with the ESRD patients. Many of them walk around with a chronically elevated troponin at baseline. So what are you going looking for is a change from their baseline. If their usual troponin is 0.05 and now it's zero point 0.5, that's significant. If it's always been zero point 0.5, that's less helpful. Compared to prior values, this is critical. Step 3: if ACS is suspected, give aspirin 325 milligrams, chewed, not swallowed. You can do this while waiting for the ECG. Don't delay it. Step 4: stop hemodialysis if the patient is hemodynamically unstable. If the blood pressure is tanking, if the patient is becoming altered, or if you're concerned about active ischemia, stop the treatment. Dialysis can wait, saving the myocardium cannot. Step 5: if you suspect a type A dialyzer reaction, stop hemodialysis and do not return the blood. This is a key distinction. In most situations, when you stop hemodialysis, you return the blood in the circuit back to the patient. But with type A reaction, the blood has been in contact with the allergen, the dialyzer membrane, and returning it can worsen the reaction. Clamp the lines and disconnect. Treat it like any anaphylaxis protocol from there. So let's talk about when this moves beyond your scope as the on-call nephrology fellow. You escalate immediately if you see ST changes on the ECG, whether it's ST elevation, ST depression, or new T wave inversions. Get cardiology on the phone. Do not wait for the troponin to come back. You escalate if the troponin is rising. A single elevated troponin in an ESRD patient is ambiguous. A rising trend is not. Serial troponins tell the story. You escalate if you see signs of tamponade. Think of Beck's triad: hypotension, muffled heart sounds, and jugular venous distension. In practice, you might not get all three, but if a uremic patient has chest pain with dropping blood pressure and rising JVP, tamponade should be at the top of your list. That needs an emergent echo and possibly a pericardiocentesis. And you escalate for any hemodynamic instability, sustained hypotension, new arrhythmias, or clinical deterioration despite your initial interventions. All right, pearl and pitfall time. The pearl: ESRD patients often have silent MIs. That means they can be having an active myocardial infarction with minimal or atypical symptoms. Maybe just some nausea, maybe just fatigue, maybe nothing at all. That's why your threshold for getting an ECG should be extremely low. If there is any doubt, get the ECG. Takes 2 minutes and it can save a life. The pitfall: don't attribute chest pain to uremia or it happens every session without ruling out ACS first. I've seen this happen. A patient complains of chest tightness, someone says, "Oh, that's just their usual thing," and nobody gets an ECG. and then 2 hours later, you're coding that patient. Don't let that be you. Rule out the bad stuff first, and then you can call it benign. Here's your cheat sheet for this one. Same deal as the last time. Pause the video, screenshot the slide, save it for when you are on call at 3 a.m. Chest pain during hemodialysis. Rapid response. 1. 12 lead ECG immediately. 2. Troponin compared to baseline. 3. Aspirin 325 milligrams if ACS is suspected. 4. Stop hemodialysis if hemodynamically unstable. 5. Type A reaction, stop hemodialysis, and don't return the blood. Escalate if ST changes on ECG, rising troponin, signs of tamponade, or hemodynamic instability. Pearl, ESRD patients have silent MIs, low threshold for ECG. So keep it simple, keep it systematic, and never ever assume chest pain is benign until you've proven it. That's on call series number 2, chest pain during hemodialysis. Next up in the series, catheter won't draw. You're going to get this call constantly, and they are very specific, systematic approach to troubleshooting it. I'll walk you through every step. If this video helped you feel more prepared for on call, hit subscribe and turn on notifications so you don't miss the next one. And leave a comment. Tell me about a time you got a chest pain call during hemodialysis and how you handled it. I'd love to hear your stories. Thanks for watching. Stay sharp, and I'll see you in the next one.